It is just a huge honor for me to finally get Jim Boyd to come on the show. I've been trying for 4 years. He's Dr. James Palmer Boyd, DDS, developer of the NTI therapeutic protocol, clinical consultant at the Neurology Center of Southern California, works at the offices of David Urich, an insider's guide to parafunction. Every day for 11 years in a row, Jim Boyd woke up with a headache. Typically a level 4 to 6 in pain with the occluSION full-blown migraine. While as a dental student at USC in '85, he was a senior resident in their TMD clinic, but the classic splint therapy that he was taught somehow allowed his own headaches to intensify as he has simply clenched harder on the splint than without one. 3 years into private practice, Jim determined that it wasn't his occluSION that was the cause of his headaches, but the frequency, duration, and most importantly, the intensity of his occluding, that is clenching, that was perpetuating his pain. A few years later, he developed the therapeutic protocol for an enhanced deprogrammer, a device that would provide for incisal guidance in any mandibular excursion, thereby minimizing clenching intensity. The device that we now know as the NTI was ultimately approved by the FDA for the prevention of medically diagnosed migraine pain. Jim then spent 5 years with neurologist Andrew Blumenfield treating migraine patients at the Headache Center of Southern California, where they published several studies together, including the most recent placebo-controlled crossover study, concluding that the NTI to be the most effective FDA-approved migraine prevention modality by the FDA. And what year did you get out of school? Was it 85?
Yeah.
Because you were lecturing right out of the gate. I can still remember going to the Arizona State Dental Association, and you were speaking, and I sat in the front row. I had no idea what to expect, and you blew my mind. I mean, I was child's play. You had everyone in the room mesmerized. And my opening question to you is just simply this. Why is it that when kids come out of school and you say, explain to me endodontics, they get it. I mean, so many things, fillings, root canals, extractions. They pretty much agree on the fundamental basics. They might not agree on the treatment plan or the materials, but they agree on the basics. And then you switch over to TMD, TMJ, whatever. And I mean, it's just like the religions around the world. There's just Catholics and Christians and Muslims and Hindus. And why do you believe that? Am I describing it correctly? Do you see it that way too?
Oh, yeah. And I think I figured it out. Why? When someone talks about you get out of dental school and you've got all those modalities, and they say, well, what about your occluSION? I mean, you need to see an occluSION guru. And you think, well, why is this occluSION so mysterious? And I think here's why. Your first day of dental school or soon thereafter, you've got an articulator with mounted models on the articulator, and you set it on the bench and you let the thing sit there at rest, and all of the teeth are occluding all the time. When you go away at night and you come back the next morning, they're still occluding. So when someone says, what about the occluSION? You go, well, there it is. Why is this one pathologic in a different occluSION, like a class 2? Is that scary? Or class 3 or class 1? I think the problem started out. We had an articulator, and the intensity of the occlud-ING was equivalent to that of the weight of the maxillary model. That was the including. The occlude was the weight, the gravity pulling down on the maxillary model, and that was always that way. Everything we did was to confine to that force that gravity was putting on our wax up or a build up or anything like that. What really drove me crazy was that concept. And so at one point I started to change everything I thought. And the most significant thing was to change the term of occluSION to occluding, because occluSION is a verb. On the articulator, it's not in rest position. It would have been great in dental school if they said, okay, everybody, take your articulator and glue it to the underneath side of a shelf. Take the maxillary portion, glue it up there, and so let the mandible hang. We'll put some rubber bands on it, and the teeth won't be touching. And you have to, with your own hand, grab it and push it up with the same intensity that your patient is going to do. And so how hard do these patients do it? That's occluSION. Nobody knows. Some people are going to do it ridiculously intense. Others, never. So people can have the goofiest looking occluding scheme and have no symptoms, nothing. Others can have perfect occluding schemes, the perfect class 1 and all those things, and they can be miserable human beings, not because of their scheme of the occluding teeth, it's because the intensity of the occluding. So once you start to think of it in those terms, everything that Dr. Dawson would say in his book, suddenly those secret code words made sense to you. Like, why do you want to have instant posterior disclusion in excursive movement? And you think, well, that's a huge term. That's hard to think about. Well, first of all, if someone is already clenching, you have to start there. Isn't it interesting? Dentistry starts at occluding. We don't say to the patient, close and open, because they should be open already. We walk and go open, close. Now open, close, open. We always start out with open, assuming they're closed. It should be close, open. So someone has to start out occluding already. Now they're going to grind to the side, and we say we need instant posterior disclusion. Doesn't that assume something else is still occluding? Wouldn't it be great if everything just discluded? There'd be no intensity. There'd be no joint strain. There'd be no tooth wear. There'd be nothing. We stipulate in dentistry, teeth are occluding. The term is occlusion. We stipulate it's always happening. We have to assume it. It wouldn't be great if no one ever occluded unless they're chewing food and their teeth touch. So we go in excursive movement, and that doesn't mean the jaw's moving to the side through the air. It means the teeth are occluding in the excursive movement. We've stipulated the teeth are occluding. We've stipulated the elevators are going to be contracting, and they keep on doing it. So mandible moves sideways. Actually, they're grinding sideways. We want instantaneous posterior disclusion, which is the magic moment. Why? Why? What's the big deal? Because the moment you move sideways, let me back up 1 second. If someone clenches dead center, perfect, bilateral contact, they can squeeze as hard as they want. We call that joint stability. We call it, it's really joint immobilization. There's no joint strain at all when you clench dead center. That's why we modify full coverage splints and polish them up just right so everything touches at the same time. It's balanced. Clench all you want, no joint strain, no tooth wear. You move sideways, things start to happen. Why do you want instantaneous posterior disclusion? Because as soon as your jaw moves one direction, one of those condyles is starting to be distracted more than the other. If posterior teeth are still touching somewhere, that's the green light that has no governor on the clenching engine. You cannot contract the elevator muscle, which is the temporalis is my favorite. It'll go all day long. The temporalis cannot contract with pathologic intensity unless molars are touching or canines through their long axis. If the molars aren't touching, you can't do it. So let's go sideways. You're going to go sideways. If the molars are still touching, clenching can happen with such an intensity to put a tremendous amount of vector forces on the distracted joint. So that's why they say instantaneous posterior disclusion, here comes the next part, with transition to incisal guidance. And I listened to that. I said, why won't the incisors just get cracked in half if you transition to incisal guidance? No, because the other first rule was molars have to be touching in order for the clenching engine to be ungoverned. So with that in mind, that's what that whole NTI business is all about. It's just now borrowing that tried and true dental concept of occlusion, that if someone's going to be clenching, and dentistry assumes everyone will be, that's why we design everything that we do. It's not forces of chewing, who cares? It's the forces of tooth against tooth, jaw against jaw. So our whole goal has been now to get to incisal guidance in the event that this patient happens to be the intense parafunctioner of all time. So an NTI just is instantaneous incisal guidance. So long ago, when I'm in Arizona doing my first lectures, someone would usually say to me, now be careful. There's some panky people out there and they'll have you for lunch. You know, that's a weird concept that you're going to present today. I thought, you know what? They all get instantaneous posterior disclusion and transition to incisal guidance. What's wrong with starting with incisal guidance? So I can just start there. If someone's going to start clenching their jaw, how about incisal guidance as soon as you can? Why wait till them to clench first and grind to the side? So when it was here, I just did it. It took me 10 minutes. In those days, it took me hours. I didn't know how to get there. So when you present it that way to all the Pankey grads, the Dawson grads and stuff, they go, oh yeah, makes sense. NTI, it's cool. You just have to use their terminology.
Would you say that TMJ or TMD, I know people are triggered by those words. I mean, the endodontist are trying to get people to stop saying root canal and say endodontic therapy, and the TMJ people are saying, well, it's TMD, but the consumer calls it a root canal and TMJ. Is it now a specialty? Would you say that whole everything, your life's work, would fall under oral facial pain now that the ADA made that a specialty, or not so much?
Probably, but there is such a huge arena in oral facial pain of conditions that don't include any, I'll call, parafunctional disorders. But when you think about if every patient never clenched their jaws or clenched in excursive position, I don't care about grinding, by the way. You know, if you're grinding your teeth, you can't be squeezing vertically very good. I have two directions. You clench this way and you grind that way. If you're not elevating your mandible, your teeth aren't touching anyway. Who cares if your jaw goes side to side? So bruxism, to me, that definition, it's the intensity of jaw clenching with or without forcible excursive movements. So if there were no intense jaw clenching and everyone was at rest position all night long and they had the 6 or 8 times their teeth might glance across each other when they swallow, there's not a whole lot of temporal mandibular disorders going on. But since we can't control that, we sort of have stipulated that, then this falls into this arena of TMD. And in my experience now, and this is my whole presentation is on these few things we're talking about. Someone can clench dead center as hard as they can. They will have 0 tooth wear, 0 joint strain and discomfort. They will never tell you that they have a jaw soreness or joint pain or sore teeth, because they don't. They're not going to tell you that they have migraines because you're a dentist. But if they clench, and if they clench in a protruded position, they'll have a stiff and sore neck and a headache behind their eyes. But that's it. They're not going to tell you that. All these different positions that the mandible arrives in when the patient then clenches has different pain presentations. And in the patient's pain presentation, the position of their jaw clenching isn't the only thing that is causing their pain, but it sure can enhance it. In my time I spent with Andrew Blumenfeld at the Neurology Center in Southern California, they see our patients all the time with the headaches that we are the best at treating all the time, and they don't have any ability to do anything about it. And I start to see that. And what I learned, matter of fact, here's a quick little aside. I'm with Andrew Blumenfeld and at this neurology headache center, and all he does is specialize in seeing headache and migraine patients. And as I learned about what they were doing in migraine, and their goal in migraine is to minimize the degree of nociceptive input, that's negative input, into the trigeminal sensory nucleus. In the world of migraine, the goal in prevention is to eliminate as much of the noxious nociceptive input to the trigeminal sensory nucleus, because once the sensory nucleus gets rather fatigued, they call it dysmodulation. To modulate means to respond appropriately to input, and dysmodulation means making the wrong choice for the input. Migraine is the secretion of neuropeptides upon receiving negative information, and it sort of overshoots. It doesn't do what it needs to. It does way more than it's supposed to. So I'm observing this thing, and the neurology teams are trying to minimize nociceptive input from the first and second division of the trigeminal nerve, nerves that, of the dura, nerves in the sinuses. So I said, Andy, when someone clenches their jaw in an excursive position, they're straining their condyles, their joints, and they're rocking their teeth in their sockets, and they're driving their musculature near capacity. What a massive amount of nociceptive input that is. And he said, and I'm all excited about it. He said, Jim, we're neurologists. We ignore the third division. That's you guys. And if you guys say he doesn't have TMD, or you made a mouthpiece and they don't get any better, we figure it has nothing to do with it. And my contention was, they all have had these mouthpieces, and they say, oh yeah, I got a splint from my dentist, and I think my headaches didn't get better, might have got a little worse. And I thought, that was me. I had a mouthpiece. When I was in undergraduate dental school, I went into USC dental school as a patient with my headache that I had all the time, and they made me my flat plane splint. I don't think I got any better. As a matter of fact, after a few days, I thought I might have been a little worse. When I went in back to the dental school as the patient, they said, well, here's what you got to do. Wear it for a night, take it out for 2 nights. Wear it for 3 nights, take it out for 2, put it in for 1. And the whole point was, don't get familiar with it. Because as soon as you get used to it and comfortable, you'll just go back to clenching on it as hard as you could before. So you make sure you do. So they knew what my problem was. I knew what my problem was. And in the neurology clinic, all they know is a patient says, oh yeah, and I saw my dentist. He thought I had TMJ. I wore the splint for a while. Those are expensive. And here I am. I think I might have got worse. So the TMD world, to the neurologist, they're like, really? You know, they're really suspicious that they just, oh, what are they going to do? I mean, all they know is what they see, what they say. So I'm all excited about that. And the neurologist says, look, we do the 1st and 2nd division. The 3rd division, that's you guys. You have an entire 4-year school just about the 3rd division of the trigeminal nerve. So my big passion, because I was the patient for such a long time, is in prevention of migraine. The number 1 disability in women under 50 is migraine. Women under 50, that's who comes in to get their teeth cleaned all the time. They keep their appointments. They're making appointments for everybody. Those people come in and out of our office all the time. And if they're just what I call primary clenchers, won't have worn teeth, they're not going to have jaw joint problems, and we won't know to ask them. We do a lot of other screenings in our clinics, but there's some things that we could actually incorporate to what we do every day and help a lot of people. And in my world, when I first modified my own personal splints, I had a flat plane splint, and I'm clenching on it all over the place. And I'm 3 years into private practice, and I put an anterior midpoint stop on the splint, and I thought, okay, let's go. Because I remember I was at a Terry Tanaka lecture years before, and he said, look, in the patient in acute muscular distress, put an anterior midpoint stop on the splint, get them out of pain, and about 3 days later, take the stop off the splint. I thought, if an anterior point stop is so great for acute muscular distress, why can't it be worked? Why doesn't it help chronic? What's wrong with that then? So I put this bump on the front end of my splint, and then dang it, the next day I woke up, I felt a lot better, and 2 or 3 days later, I'm feeling a lot better. And then out of nowhere, at the end of the week, I had a whole new headache presentation. My back of my neck was bugging me. My face was sore and stiff, and I thought, what is going on? So I take my splint out of my pocket, because I had it with me all the time, put it in my mouth, and instead of biting down and hitting the bump, my natural arc of closure was in front of this bump. I was clenching protrusively when in front of the bump and biting on my molars on the splint. And I thought, my little condition is going to look for a way to clench no matter what I put in there. It's going to find it. So the next goal was, I call it, I have to be there when I get there, meaning I had to extend this bump anteriorly so that when I protruded, I was still having incisal edge contact. One thing leads to another, and I move sideways. I got to check for that. I have to lower the vertical. And that's really, that's really how the NTI device was sort of developed, because anterior deprogrammers have been around forever, and they're for tap, tap, tap on the chair. And so I call the NTI, it's an enhanced deprogrammer, meaning you have to modify the design to be there when the patient gets there, because they're going to protrude. They're going to move excursively. So you want to be there with incisal guidance. So back to where these patients are, these migraine sufferers. We'll talk about women under 50. They're in there getting their teeth cleaned, and maybe we could ask them, because this is what I did in my private practice, and I got so busy seeing headache migraine patients, I just split off and did that exclusively. I would ask them 2 questions. Okay, now let me ask you a question here. On a scale of 0 to 10, and a 10 is the worst discomfort you can imagine above the shoulders. And you don't say headache, because they'll already start to rule you out as for knowing what you're talking about. So you say, so above the shoulders, a 10 is the worst pain you can imagine, and a 0 would be you feel fabulous. And you have to say it that way. You feel fabulous, because, by the way, people that wake up with a level 4 headache every day, that's not a headache. That's usual and customary and normal. So a 0 is so weird and odd to them. You can say fabulous, because that's what it is to them. It's so bizarre. So how many mornings a week do you wake up with a 0? You feel fabulous. Then you wait. You don't say anything. You don't prod them along, and they will go, well, I mean, when usually, I don't. It's they will tap dance all over that. No, seriously, a 0. How many mornings do you wake with a 0? Well, I mean, no one really gets it. I say, pretty much I can do. They'll come out with, they might say, I don't know, a couple of times, once or twice a week. Yeah. So, okay, that's good. So 5 days a week, you wake up with a number. What's the average number that you have? I don't know, 3 or 4, maybe sometimes a 5. Say, so if 4 or 5 is an average, if you woke up with a 7 or 8, would you be shocked and scared? And they go, no. You'd be upset and disappointed. They go, yeah. You got to hurry up and take as many medications as you can before the day gets going. Otherwise, it's out of your control. They go, oh, yeah. If you woke up with a 2, would that be amazing? They go, oh, that'd be great. If you woke up with a 2 5 days in a row, they go, never happens. So if you woke up with a 0 5 days in a row, they go, impossible. That same situation, that same scenario, I've had a chance to do a couple of presentations in front of physicians. And I'll say, can you imagine someone waking up with liver pain 5 days, 5 mornings a week at a level 5? And sometimes the liver pain is beyond their comprehension. Of course not, because somehow we've decided that headache and migraine, it just sort of happens. The point is, nobody dies from it. No one dies from migraines. They feel like they want to. And if these patients were to actually tell their neurologist, every day I wake up with a headache, and I was told I was taking too many medications, and they're all told that, well, that's headache overuse, and you're having rebound from too much caffeine and all that excedrin you're taking. So the patients learn, nope, not telling them, because the goal is to improve the quality of their life, because their migraine, when they get their migraines, it changes the quality of their life dramatically when it comes out of their control. It's a disability factor that it becomes overwhelming for them. So neurology takes a look at migraine events and aborting the migraine with new medications, or trying to provide some sort of new style of medications to prevent the attacks. But those are the tip of the iceberg. And my approach has been to say, what is underneath pushing the tip of the iceberg up? And I think it's this almost secretive nocturnal clenching that it goes no one sees it happen, no one hears it happening. It happens more in women than men. And I think for dentistry, we have a fantastic opportunity to help more people than you could ever imagine. I mean, it's when someone said, I remember about a long time ago, bleaching was the big thing, and then now it's, snoring and apnea is a big deal. They're great things to help people with, and they're a little bit complex to treat. Not bleaching, but by treating migraine is in a dentist's hands, it's something that you can profoundly change someone's life, and it fits right into your practice all the time.
So, my God, I could listen to you for 40 days and 40 nights, and you're so amazing. I want you to, I want to just break in and keep it real for just a second here right now, and that is the fact that these kids come out of dental school, and about a quarter of the people listening right now are still in dental kindergarten school, and they're going to go back, and the only reason they became a dentist is because their mom was, and she wants to practice with her mom. And her mom, this is the reality, Jim. I'm going to pull you back into reality. Anybody says anything to do with TMJ, just anything, they just stop. They radio the front desk. The front desk looks up the insurance, see if they cover a night guard. If the answer is yes, they tell the assistant. She goes and gets the alginates and comes in the room, takes upper and lower impression, sends it out to the lab. And then a week later, they get the splint. The assistant tries on, makes sure the bites are even. The doctor comes in and looks at it with a mirror for all of like 3 seconds. And that is TMJ for 90% of America. And if you think I'm crazy, you might be right, but I'm still, this is... And Nogales, Arizona is the largest removable framework lab for partials there is. And they ship them all to Nogales because then they drive them across to Mexico. And they have this foundry there. And I go down there. They do about 1,000 to 1,200, sometimes 1,500 cast partials a day. And I look at the lab scripts. 90% of the lab scripts just say partial, you know. They didn't cut a receipt. They didn't survey it. I mean, they just took an impression, make a partial. And the people that work down there are saying, God, these gringos, I mean, they could have at least cut a receipt, or they could have helped something. So what would you tell this little girl who loves her mom, and the world, according to TMJ, is that? How does she start there and end up Jim Boyd Jr.?
Well, I look at it this way. The enemy of dentistry is force on the teeth. And when you think about why do we prep crowns with a 6-degree taper? Well, it's so that in lateral forces, there's that word forces, it's less likely to dislodge. Why in the amalgam days, why did we compact and compress that so vigorously so it would stand up to forces? Why do we have bond strengths? Why do bond strengths have to get greater? Not so they can chew food, it's to resist forces, and they're occlusal forces. And when we used to say, when someone says occlusal forces, it's as the teeth have outboard motors themselves, and they're actually doing it. Teeth don't do anything. Teeth are along for the ride. They're just embedded in the jaw, and then the mandible's moving. It's a muscle that's contracting. So to me, TMD, your first order of business before you can think of anything is to minimize the forces that are happening. Well, how do you do that? Would you do occlusal adjustments? You say, no. You minimize the forces by not giving the musculature the ability to generate contraction intensity. The only way you do it is with incisal guidance. And dental students, I heard that stuff at USC. We had a nathology course. We talked about incisal guidance and media posterior disclusion, all that kind of stuff. I would tell junior dentists, just imagine what do you need to do to minimize the patient's ability to generate forceful closure. Now, I shouldn't even say closure, because that suggests the mandible moving up through the air. It's once the teeth are occluded, you want minimal forces generated. It'd be great if you can wave your magic wand and everyone stayed in rest position all the time. So I'd have them try to think, what can I do to minimize the intensity that they can generate? And incisal guidance therapy, or NTI therapy, sort of evolves from right there. That's where I try to start them thinking.
I want to tell you, seriously, from the bottom of my heart, you have how many posts? You have 6,913 posts on Dental Town. I mean, 7,000 posts on Dental Town.
Hey, and I say the same thing every time.
No, you don't, though. You have been wading into an area where, again, you got the Panky Dawson people over here. You got all these different views, and some of the TMJ guys are extremists. I mean, I've heard statements like that every orthodontist post-orthodontic treatment, the occlusion's been destroyed. There's no more curva speed, curva Wilson, taken from canine guidance to group function. And I'm like on this podcast. So you're saying that all 13,000 orthodontists licensed in the United States practicing today, all they do is destroy occlusion? Absolutely. So I want to ask you that question. What letter grade, or what do you think of the fact that I don't think orthodontics is for health? I have edentulous patients that are obese. I think orthodontics is to be as pretty as a peacock to increase your chance that you can spread your gametes with someone else and have offspring. That's what the whole damn existence is about. You only have one job. You're supposed to find someone and shower them with gametes and replace yourself so that when you die, that's your only job. And I did it 4 times, and my 4 boys have done it 6 times. So I think the Ferran family gets an A. It's just about being pretty. I look at some of these cross bites and things like that, and what I think is amazing about the human condition is that so many people adapt. I mean, they were born with the wrong teeth, the wrong bite, the wrong cross bite, and a lot of them adapt, and some don't adapt. But what do you think about the whole orthodontic industry in terms of, does it make America, the world around, better prepared for TMD? Does it even have an impact on it? Does it make it worse? Do you cry at night because you are missing the curva speed and the curva Wilson?
No, I barely remember what those are.
Do the ghost of Spree and Wilson ever appear in your room at night? Like,
So
what was that Christmas movie where the ghosts appear?
I mean, consider this. You could take 100 sets of mounted models with every kind of goofy occluding scheme you can imagine. They're cross bites and class 3s and overbite and underbite, 100% overlap, everything you can imagine. 100 of them, line them up in a row and sit there, and then challenge anybody to say, pick out the people who are miserable, pick out the people who are pain-free, pick out the people who are happy or miserable. You can't do it. You cannot tell by their occlusion, that is their occluding scheme. That doesn't cause any discomfort at all. What they do with what they have is the big problem. So let's say you've got the ideal occlusion because the patient went from this goofy occluding scheme, went through orthodontist, and there's this beautiful class 1, everything looks gorgeous occlusion. And they're over in the migraine clinic because they wake up every day with a level 4 headache, and they have to take their Imitrex 4 times a month, and they're miserable because it's their occluding, what they have with what they do is their problem. And so we can rearrange and adjust and allow for the most ideal occluding schemes, because we're going to stipulate they're going to occlude or clench their teeth together tonight. If we can arrange those teeth in such a manner that, look, if they clench dead center, the teeth are fine, the joints are fine. If they grind to the side, we want to make sure there's none of those molars are touching anymore. We don't kind of give them the opportunity to clench over there in an excursive position. We'll disclude them. So that's what's orthodontics is great for that. But then again, I keep coming back to, you could have the stupidest looking teeth of all time and feel fabulous, or the most beautiful teeth of all time and feel terrible. I think orthodontics is terrific because there's just a demand for it. I don't think it's a therapeutic demand. I don't believe that's orthodontics is a therapeutic modality to cure the patients that I'm seeing. They might say, oh no, my patient had orthodontics and they were a bad joint pain patient and it all went away. Really, when they wake up, they feel fabulous. Well, they go to a neurologist for that. That's different. So to answer your question, regardless of what orthodontics is designed to do therapeutically, I know cosmetically, I love it. And I think it can be very, very helpful for some conditions. If someone truly is having a problem with their excursive movements, they can deal with that. And I think, well, if the patient thinks they look just fine and they already have a spouse, so they're not worried about that anymore, they could wear a temporary occlusal scheme at night because that's when the pathology happens. So I default to that. You can wear a removable temporary occlusal scheme when you're asleep.
Okay, Jim, I'm going to ask you again. I got a quarter of my crew listening to you right now is still in dental kindergarten school, and
Yeah.
I know the first 100 questions they're going to ask about you right out of school. And so the first one they're going to ask is, on those night guards, should they be hard or soft? Because I heard that if it's soft, it's going to stimulate and you're going to start chewing. But if it's really hard and slick, it's going to be slidey. Should it be thick and chewy or hard and slidey?
Okay. If you're going to restore all of the teeth, pick an arch. If you're going to restore all the teeth in the maxillary arch, you just get to put a brand new crown on every one of them. Should you use porcelain or rubber? Like, well, that's dumb. Well, yeah. I mean, it depends on what the purpose is. You wouldn't put rubber teeth if you're going to try to chew food and break things. If all you did with your teeth was grind your teeth, it'd be nice if they were rubber and you disperse the forces and things wouldn't be so traumatic. So I just now made a diagnosis. What's the diagnosis that you're treating? When this patient goes to sleep tonight, are they going to clench like crazy? Or do they not clench with such intensity that they are able to move their jaw side to side? That is pure grinding. They never stop. They never slow down and stop to squeeze really hard. They keep on moving. If all they're doing is moving side to side, yeah, you can wear a softer component, a soft material, and there'll be less trauma. That's great. If they're going to squeeze really hard, you might want to have something a little bit more rigid that they can slide on, and then when they squeeze on, but I'm back to they're going to clench on it anyway. And so now we're talking about the design of the occluding scheme, and it's the occluding scheme which is therapeutic, not the texture of the occlusal surfaces, but it's really the occluding scheme that dentistry tries to manipulate in order to control parafunction. So when someone says, well, what kind of spins? Look, if the patient's not symptomatic, it doesn't matter. You can actually get away with anything. That's why the things in the in the drugstore are fine. You can buy the devices you can buy at CVS. If the patient is grinding their teeth at night and that's their only issue, those are fine. If they're primary clenchers, they probably don't even know that they're doing it, so they wouldn't know to get that kind of a mouthpiece anyway.
I want to. I got to do my little history thing because I'm just a little fan crazy right now talking to you. But my God, I remember all the way back in 2001, after Y2K, Dr. James P. Boyd, DDS, being interviewed by Diane Sawyer on Good Morning America. And by the way, on YouTube, that just has like something like a gazillion, bazillion, quadrillion views. I want you to go back to that time and place. I mean, in American history, what was that like? Being on with Diane Sawyer on Good Morning America. Where was TMJ and the Nti Splint? Where were you at in your journey? My gosh, what would have been 20 years ago, two decades ago?
So in the year 2000, Horace Kulzer had licensed the patented technology of this enhanced deprogrammer, and they applied to the FDA for its approval for use. But the only indication for use that they could get at the time was for treatment of clenching and grinding. So that's all it was. There was no migraine indication or anything like that. So that was in the year 2000. I was out there doing my lectures, and the Horace Kulzer was sending me all over the place. At the end of the lecture, I'd say, and so now here's the concept. I build up this big story, and here's how migraine happens, and here's what we're trying to prevent, and here's how it all comes together. And a lot of guys that are now NTI Jedi Knight by now, but they said they were at those early lectures and said, man, we at the break, we said, this guy's out of his mind. He actually thinks the FDA will someday approve this for migraine prevention. Well, in the meantime, Horace Kulzer had funded quite a large study of migraine patients and using a flat plane splint and comparing to the NTI, blah, blah, blah. And eventually, long story short, The FDA approved it for the prevention of medically diagnosed migraine pain. Well, that gets approved, and all of a sudden there's some news stories, and ABC News does a couple of news. I did a news feature in San Diego where I was living at the time, and so the national affiliate picks that up and they show it around the country. So here I was one day in September. I get this phone call, and this person says, "Hi, I'm the science editor for ABC News. Can we talk to someone about the NTI?" I said, "Well, you can talk to me." "Well, we want to talk to a real doctor. Because you talk to a physician." I go, "You won't find anyone that even knows what you're talking about." "Well, can we talk to you?" "Well, yeah, I know all about this thing." So I talked to this editor for a while, and they said, "Well, that's quite fascinating, and we'd like to have you on the show." This is a Tuesday. He said, "We'll have you on the show." I said, "Well, really? Let me go check my calendar and see when." They go, No, tomorrow." I said, "Really?" They go, "Yeah. Where do you fly out of?" "Well, San Diego Lindbergh Field." So, "Okay, we'll call you right back." So I hang up the phone. It's like 11 in the morning. And I'm like, "Kathleen, you'll never guess." I'm calling upstairs. Phone rings again. They said, "Okay, you're on the 4:00 flight to Newark. We'll pick you up. We're going to drive you into the city. We're going to drop you off at the hotel. The next morning, you got to get up at 3 in the morning and be out. And the page will pick you up and walk you across the street to the green room, and they'll powder you up." And no offense, Howard, I had a perfect hair day that it just came out perfect. So they lead me in the green room, and then all of a sudden I'm they put the bib on you and they're doing your face. And the gal said to me, "So what are you here for?" I gave her the little thumbnail sketch, and she said, no kidding, "Ugh, I wake up with headaches all the time." And the other girl doing makeup says the same thing. "Oh God, this is just everywhere." So I go in, they lead me in there, and I sit down, and I'm really nervous. I go, "What if they ask me these hardball questions?" I thought, how could they do that? I already told them what they could ask me, so that was easy. So Diane Sawyer asked me these questions. I gave her all the answers, and that was done. And she's like, "Wow, this is crazy." And so the bit ends, and she's still asking me more questions. And I said, "Diane, go. You got things to do." There's a guy standing over there with my suitcase. They put me on a plane and flew me back. And within 24 hours, I was back home. That was it. What's really creepy is it was September 4th, 2001. And it's September. Anyway, exactly 1 week later was September 11th, 2001, when the world changed. The only reason that I think was helpful to me, because it was such a different concept, that if there was a news cycle would start about the NTI and migraine, I think it got shot down completely, because no one had ever heard of it. There was no advocates for it, nothing. It gave me a chance for the next 10 years to slowly grassroots sort of build. It kept lecturing. It's like doing all the small clubs. You just kept going out, lecture, posting on Dental Town. It was the same story over and over and over. And people like Mike Melkers and I are huge friends. We started out kind of weird because I'm posting about this concept, this NTI concept, and he's very suspicious. I used to call him the upstart Melkers, like, he didn't. Well, now Mike has an incredible occlusion course, and part of the component that makes it work is the enhanced deprogrammer concept that he's worked into it. Steve Bender is another. I mean, if I could know a third of the stuff that Steve Bender knows, man, I'd double my knowledge. But
out of Dallas.
Yeah. When Steve would see me posting, as the story goes, he thought the first thing he wanted to do to see if he could, with research, investigate, see if he could prove me wrong. And every time he looked at these things I was saying, he goes, "No, that's actually correct. No, that's actually correct." And so he said, "Oh, I guess that's legit." And of course it was, because it's been in all of our textbooks all this time, this concept of incisal guidance. But anyway, I think that Diane Sawyer gig, it's almost kind of a surreal thing. And that's what's so great about YouTube. It's almost like brand new out there.
Well, the one thing I think social media did amazing is it leveled the playing field. I mean, when we grew up, I mean, ABC, CBS, NBC own the news, and that was better than Russia's Pravda news. I mean, they just had the government, but we just had three. And what I really love about social media is it levels the playing field. It gives everyone a platform for their voice. And a lot of people, when they started hearing him talk, like say Rush Limbaugh, who just passed away today, they didn't like what he was saying, and now they're trying to censor people on social media and take down their platforms and don't let them speak. And I'm like, well, what is the opposite? Then you're not going to know. I mean, the first 110 billion Homo sapiens lived. We don't know their names. We don't know one of their names and one thought they had, and that's not where I want to go back to. I'd rather know what all 8 billion people think about everything, and then you would have a starting point to say, okay, what works, what doesn't work. Okay, this is going to get you killed, and this is going to make you more likely to reproduce and have offspring. And that's why on Dental Town, the most controversial thing I've done on Dental Town the whole time was the number one complaint is anonymous people. So you'll post your great case, and then somebody, dentists, they're so God, they're thin skin. I don't know where they get it from. Maybe I'm pathological, but hell, a Yelp review, and they're ready to jump off a building. I mean, so they don't even know. They couldn't even pick this person out of a police line. It was like, and I went to him and he sucked, and the dentist like crying, and oh my God, they want to get lawyers. Just flip and relax, people. A quarter of all sapiens are batshit loony. Okay, and I want to know what they think, what they're doing, and how are we going to help them keep their teeth, last longer and all that kind of stuff. But it's all about free speech. But the reason I let it anonymous is, I called one of my dental moms. I have several dental moms. Linda Miles was one. So is Gordon Christian's wife, Rella. And I said, Rella, what do you think about this debate? She goes, Howard, dentistry has to have a place where you can ask a stupid question. And if they don't have a place to ask a stupid question, anonymity, you're going to hurt the profession. And I said, exactly. And it even gets weirder than that. I mean, some of these dentists have, they'll have an anonymous name and then their real name. Their real name is when they do a root canal with a puff of sealer out 4 apexes, and then another name where they're they're failing and they can't go wrong. But I just want to do what's right for dentistry, and that's going to mean transparency and checks and balances, competition. So I want to know what you think, and you need to have a safe place to be able to ask Jim these questions that he's just so. I can't believe how much time you've taken in your life to answer these 6,000 questions. But I'm going to ask you another thing.
Yeah.
On your YouTube videos, your YouTube channel is my gosh, it's he's got how many videos do you have? You have 36, 12, 18, 24. You got some amazing videos. But people want a main question with you is, what is the NTI? How is that different than the full arch coverage? And can I fabricate this chairside, or do I need to send it to a lab? I mean, that's ground. That's the first step up the Jim Boyd ladder. She's went into practice with her mom. Her mom just upper lower alginate. It's a flat arch deal. So Walker, what is the difference between what NTI is, and can you fabricate a chairside?
Sure. Oh, by the way, I want to back one thing on the website NTI devices. There's a link on that thing, and I've assembled a series of 6-minute YouTube videos, and it's the assembly of my typical 2-hour presentation about occlusion, occluding, parafunction, that kind of thing. So there's the foundation of the end of the story is incisal guidance / NTI. As far as lab goes and that kind of thing, there's two kinds of dentists. There's the kind of guys that make everything, and the other guys like, I don't do anything, and they send everything out to a lab. Now, for me, I like making my own stuff. So an NTI, the initial original NTI device was a prefabricated shell, sort of a elbow macaroni shape, but more like a taco with this special bump on it that you reline with a thermoplastic and adapt to the either maxillary or mandibular incisors. And oh, by the way, I've sort of changed the protocol a little bit. We talked about making a splint and you have to put in the blue paper and tap, tap, tap. You're adjusting it because it's the opposing teeth that have the irregularities that you need to fit perfectly against your splint. So, well, why am I fighting that battle? What I like to do in my NTI therapeutic protocol is I will adapt an NTI device to either the upper or lower arch, and then which is, might go from teeth 7 through 10, and maybe to the mesials of the canine with this thermoplastic material, and it has this discluding element, this incisal guidance platform. I'll make an opposing device. So on the opposite incisors, I call it a slider. It's a flat, smooth, slippery, another NTI type device that I adapt over so that when the patient closes, instead of me worrying about, one of those central incisors is tall and the other one's short or one's rotated, I don't have to worry about that anymore. I now have a point contact that's provided by 2 pieces of plastic, and they just slip and slide on each other. So that would be my chairside protocol. I typically make 2 devices at the same time, sometimes deliver them simultaneously, so that I have a slippery surface without any irregularities of a taller or shorter or rotated or tilted tooth. The occlud-ING scheme is now under my complete control. I don't have to grind on any plastic at all. Well, that's what I like to do. If someone would rather not, they can always take impressions and send it to their lab. They can send it to Keller Lab or National Dentex, which owns Keller Lab. There's a big network of National Dentex labs. Glidewell Lab is now just licensed because Glidewell is super excited. I think they're going to be very, very big in promoting this whole concept, because I think because they see the potential of, not that there's more people grinding there, there's patients that we haven't been diagnosing as being primary clenchers. I'll call it that. We don't have to diagnose migraine. You can diagnose primary clenching. And making an NTI device, I think Glidewell is going to be very, very big and informed. So there's plenty of laboratory opportunity to take the impressions and send it off, or you make them yourself, which I like doing. I mean, the moment you find out that a patient you've asked them those 2 questions, that, gosh, that sounds like they could be clenching at night. And the patient realizes that, well, when can I get my device? Well, take an impression, blah, blah, a couple of weeks. Or you say, oh, make it right now. I got something else to do, but my assistant can come in, fabricate. I'll come back in and check it, and away you'll go. So that's what I like about it, is that I can treat the patient the moment that I've made the diagnosis using the chairside method.
Now, I want to ask your permission on something, because it's my job to help. I own a dental media company. I'm trying to get more information out, but on your YouTube videos, if you watch, the best way to make your views just explode, if you hit the share button, it first prompts you to copy the link to YouTube. The next button is embed, and that code on Dental Town.
Right.
When you reply, if you drop that code in the YouTube icon, it goes right to your YouTube video, and they're on your YouTube channel. You get the view count, all that kind of stuff. But it's so commonly asked. Do you care if I drop some of those YouTube videos in in your thread?
As a matter of fact, that on as many times as I can, when I do make a reply on Dental Town, I'm talking about a concept, I'll embed the YouTube video snippet of that particular concept. That's what I mentioned before, the series of maybe, I think it's 20 in a row or so, or maybe it's something like that, on the ntidevices.com page. I'll pick one of those videos and paste it into my Dental Town reply.
And I also want to say this about, you mentioned Jim Glidewell, and have you read his new book?
No, there he is.
And it's his plug, Constant Change, Adventures in Business and Life, My Journey from Startup to 5,000 Employees. And I flew out there to his 50th anniversary of Glidewell. And I just want to say one thing about Jim Glidewell. When I got out of school, I started off at Pankey Institute, and I went to Dawson so many times I can't count them, and I agree. I love Mike Melkers. His mind is so amazing. I remember seeing him talk for the first time at Arizona State Dental Association. I was in love with Melkers' first lecture. But the one thing that I had a problem with dentistry is, I went out to Pankey, and the first day that Irwin talks about the A, B, C, D, F patients, and it's a whole presentation about how you want to hang out with the rich and the bankers and the candlestick makers and how the B were noise. And by the time he got to the C, D, F, but when he was describing that, I was at front row. I was young. I was in my 20s, and I was just thinking, well, the entire Ferran family is a DF. We're a bunch of Irish Catholic hillbillies from Kansas. I was just really proud of my heritage that my mom and dad weren't brothers and sisters, and I did not agree with that assessment at all. And I loved Herb Kelleher. And I thought Jim Glidewell was a Herb Kelleher who died during the pandemic last year, January. And Herb Kelleher said, if you don't keep one eye on the customer and one eye on cost, no one's going to afford to fly. And when I started lecturing in 1990, you know, I lectured 32 to 64 times a year from 1990 till now. It took a pandemic to get me off the road. And now they're trying to get me back on the road again. And I'm telling my staff, no. I mean, I've turned down 5 invitations this week paid. It's like, hell no, I'm not going to go fly all the way to your deal to talk to 200. I can talk to thousands right now without shoes on. But the bottom line is, when I used to start flying like that, the airplanes were empty. And everybody had a suit and tie. And everybody was rich or worked for corporate America or whatever. And I loved Jim Glidewell, how he took the cost out of dentistry and made a lower cost value treatment plan. And he's given so many Americans the freedom to save their teeth. And to all the pretentious dentists, he say, oh, Glidewell, they're like the Walmart of dentistry. It's like, and what are you saying? That dentistry should only be Bloomingdale's? That dentistry should only be for the rich? That dentistry doesn't have anything to say? I mean, right now in America, 50% of Americans don't have $1 in Wall Street. The top 0.1% owns a third. The 0.1 to the top 10% owns the next third. And the 10 to the 50 own the next third. And I just think it's a problem traveling the world. I mean, I've been to 50 countries and I'll reduce the world to 3 people. One has an iPhone, smartphone, just like you and me. 1 out of 3's only got a cell phone. They do not have internet connection. And 1/3 doesn't have anything. And everybody's worried about that rich one guy with the smartphone. And that's just not me. And I love Jim Glidewell. And I asked Jim, I said, where does this come from? And he was young and he was patriotic and he was going to serve America, and he went to Vietnam to serve America, and 1 year of that. And he's like, I think there might be a little more to this story. And he was a soul-searching guy, and his final conclusion is what to do with his life was to work hard to make, he was a lab tech, and he was going to work his butt off to bring down the price of dentistry and to serve the half of America that doesn't have anything. And long live Jim. And so back to the chairside. Do you have, is one of your videos better than the others on teaching you how to do a chairside Nti Splint?
I think on the ntidevices.com, there are chairside, there's a few videos showing it, and it's ridiculously simple. And I don't think, and here's what's so weird is that when someone talks about TMD, it's so multifactorial, so complex. And so, and I just think that's ridiculous. I mean, I don't see complexity as something that's expensive. Just because their symptoms are puzzling to one person, to somebody else, like, well, yeah, that makes sense. The reason why there's pressure behind their eyes and a stiff and sore neck is because they clench in a protruded position. And then next night they clench off to an excursive position, their jaw joint's sore. Sometimes they don't do that at all. They clench dead center. They've got a huge headache and they wake up. To me, that makes sense if I'm imagining what it is that could cause that kind of thing to happen. So I'm in the boat of Jim Glidewell. You know, why can't treating TMD be simple and basic? When you eliminate the most influential component of TMD, that is intense occluding, when you manage that, suddenly everything else becomes quite clear, and it's easy to treat. And if it's something that's like, wow, this is really weird, well, then you refer it out. So when someone says, well, what do you charge for an NTI? So, well, God, it's kind of, it's so simple to do. How much should I charge? It's too easy. I need to charge $700 or $800 for my splint, or $1,500 for my splint. What do you charge, Jim? So, well, I think at the dental office that I utilize them, I think they charge $700 or something like that. But get this. When you talked about insurance, check their insurance, see if they pay for TMD, TMJ, and all of a sudden you find out, no, there's no splint coverage. You can't charge them anything. And what are you going to do? This is what I've done from the very beginning with an NTI device, and I still do it today. Here's the patient in the chair, and I've made this diagnosis, and I think that they're clenching at night, and that's a component of their problem. And I think that's why they wake up with the numbers that they have, and that's why the gamut of things. I say, you know what? I think this device is going to be very helpful to you. And I don't think you care to buy a piece of plastic. I think you'd like to buy relief from your symptoms. And if there was a price on the relief from your symptoms, we could negotiate and talk about it. My fee to relieve your symptoms to your satisfaction, and in those days in the NTI development, was $1,500 for me to do this. And this is a long time ago. I'm going to make this device for you. I used to make them custom. I used to do suck downs and add the bump and the whole thing. But the point was, I'm going to make this device for you. And you're going to come in for an adjustment or a check in 2 weeks. And at the end of a month, we're going to do a reevaluation. If you refuse to surrender that device back to me, I'm going to cash your check for $1,500. If it's not worth it and you're not ready, you hand it back to me and I give you back your uncashed check for $1,500. And in those days, these patients said, heck, if you had, then let's do this. I would have paid you $15,000 if it would work, but you said $1,500, so that's where we're going to keep it. And if ultimately, a lot of times someone would come back at the end of a month and say, it's just not doing it for me, but I don't want you to quit yet. Is there anything else you can do? So in those days, there was no NTI therapeutic protocol. And I would say to the patient, well, I'd love to have that money, but I know I've got to have it such that you won't want to surrender this device. I wonder what else could be going. And I would think, what's a person have to do to still be symptomatic with this device? And the other thing is, they had to do something that I didn't do personally, because that was my reference. What if they were to go so far sideways, but they've got this upper discluding element? Imagine a discluding element right about the middle of where 8 and 9 are, the two centrals. What if they move their jaw so far excursively, they could put a lower canine and bite on an upper midline contact? I found people that could do it. I thought, well, if they're doing that, that would really be weird. They didn't even have to do that before I made the device. Now they're doing this. No wonder they've got new weird symptoms. And that's when I switched it and started making a lower device. Now the lower device, when their jaw moves way over to the side, it can't get, quote, underneath the upper canine. And those symptoms would resolve. So when the money's on the line, you're going to start thinking about what you need to do to help the patient. And to this day, I think, and I don't see patients like I used to, but Dr. Urich, who does, he still says it's $700, and that's if it works. And so like at Nordstrom's, if you come back in a month and say, these shoes don't make me happy, they go, okay, here's your money back, give us the shoes back. A piece of plastic is just a piece of plastic. It's the relief that they can get from it. And so, gutta percha doesn't cost but a few cents, but the endodontic therapy costs a lot more than that. So I sort of segued there into cost effectiveness, but if someone's curious, like, what do you charge for an NTI device? It's not the device you're charging for. It's charging for your ability to know how to make the device correctly, because I can also make a device that will make somebody miserable. I know exactly how to do it. Once I see what the patients, let's say you see some, sometimes you look at the lingual of 8 and 9, it's sort of scalloped out back there. They clench and they protrude forward. And they made that thing. If you make an NTI device that doesn't accommodate for extreme protrusion, so they could get off of it and go forward, they'll be worse. They'll have new symptoms. So the fee that you charge is really for your anticipation of not having them go through some uncomfortable times, and to help them. And then you can say, if that helps you and you want to keep your device, great. And it's a great feeling to do it that way. That's how I've always done it.
That is amazing. And what have I not talked about that you wish I would have talked about? I know that nociception or nocioception. How do you say that right? Nocioception.
You know, it's the dumbest.
Nocioception.
It's the dumbest name of all time. But NTI stands for nociceptive trigeminal inhibition. It's, I don't know how it got garbled that way, but its concept is trying to reduce the degree of nociceptive input to the trigeminal sensory nucleus, NTI. Oh, here's something that
is it nociceptive? Is that what you said? Nociceptive trigeminal inhibition tension suppression system.
I think it might be. Well, I think it really was nocioceptive, but I've also seen nociceptive. It's just dumb.
Yeah, I think it should be an O, and I like nocioception.
No, I like nociceptive. Now here's the question.
Here's the question to harm or hurt.
Let's say here's the big wrap up, because this is the big question. This is the big elephant in the room. This actually happened. I'm going to start the end of the story first. I go to my good friend, an orthodontist named Anton, and I said, Anton, I have a patient. I'm still doing some restorative dentistry, and I need you. He's got an upper molar that's sort of been shortened or sheared off. I need you to extrude an upper molar. Can you do that? He goes, yeah, I can do that for you. I said, good. Oh, by the way, this patient's kind of quirky. You cannot make a removable device such that it touches these molars that I want you to extrude. Oh, by the way, you can't put a bracket on the molars that I want you to extrude. And oh, by the way, during the day, they are going to contact that molar as often as they want. And I think they're sort of this guy's kind of a clencher. So he's going to be clenching on that during the day, and he likes to chew really hard food. So you can't touch the molar ever. You can't put a removable device that touches it. You can't put a bracket on to pull it down, and he's going to clench on it during the day. And Anton said, well, that's impossible. I can't do it. I said, isn't that amazing? Because you told me that my patients with NTIs, you're kind of concerned about that super eruption of the molars. How does a molar super erupt if you're in rest position at night and occlusally contacting the tooth during the day? It just doesn't happen. And an orthodontist will tell you, no, I can't do that. You can pay me all the money in your world. I can't do it for you. But they'll say, but those NTIs can cause super eruption. What you do see is, and this is probably a whole different lecture, but in a patient who's been clenching or grinding, but mostly clenching in positions for a long time, they have lateral pterygoids that have sort of been shortened, I'll say. Once you disclude these teeth and allow for normalization of the musculature, those lateral pterygoids, they normalize, which means they can get longer. And what you get is what we've all been trying to achieve is condyles that can seat to centric relation, that is CR. When that happens, depending on the relationship of the two jaws, as the condyle rises and seats better superiorly, the pivot points are on the second molars. And so you get the incisors during clenching start to separate more. They go, oh, you're going to get an anterior open bite because the teeth have moved. No, the teeth haven't moved. You've got some of these patients that will happen to them, and their condyles seat better. You'll get primary contact on the palatal cusp of the second molar, usually opposed to the lower distal buccal cusp, and their incisors don't overlap like they had before. Now, and the patient has a considerable incisal overlap, 50% or more, this condylar seating can happen. No one even knows. You don't even see a difference because the patient doesn't say anything. Their teeth still overlap ideally. But you take someone, for example, that had minimal incisal overlap, been clenching for a long time, they're symptomatic. You make an NTI device and they come back and they're feeling better and better. And all of a sudden they all start to notice there's a little bit of anterior open bite going on, but the patient feels great. Their condyles have seated, their musculature is normalized. And you'll see that when they go to close, they'll do this contact on the palatal cusp versus the lower distal buccal cusp. I reduce those things. I don't play around. Well, you get a natural, perfectly good tooth straight. You're doing, yeah. I mean, grinders do it iatrogenically, or they do it themselves. They grind those things down all over the place. So yeah, I will reduce upper second molar cusp. I hate palatal cusps. I'll take those guys out, because when patients move excursively, that's where those contacts are happening to create all this nightmare anyway. So I'll make those kind of adjustments. But so that was the big last question that we finished up with. It's like, what about Jim? Everyone says, oh, you're going to get super eruption. Ask them to specifically what would you want to do to get super eruption? If you're going to have action on that tooth during the day when they chew food, that's just not how you do it.
Oh my gosh, Jim, I could talk to you for 40 days and 40 nights. My gosh. I think, so last and final question. She wants to start her journey. I mean, you come out of dental kindergarten school and you're so tempted by the gardens of oral surgery, implants, clear aligners, silver diamine, fluoride. I mean, they just want to do it all. And she wants to learn more about occlusion, TMJ, TMD, migraine. She wants to be a little Jim Boyd when she grows up. Where would you set her out on her journey? She's straight out of school. She's got $400,000 of student loans, and she's working for McDental's DSO.
Okay, so she wants to spend next to $0. She goes to ntidevices.com. She clicks on the NTI CE course, and she watches those consecutive videos. I've had some dentists say, I've seen those things 4 or 5 times now. In between patients, they'll just watch the next one. They're like 6 minutes or so each one. She'll watch that thing a few times, and then she'll send the email to request free samples of NTI devices, and I send her those, and then I'll say, now, anytime you want, you just text me or email me, and or FaceTime me if you're chairside with your patient, and I'll get on and FaceTime with you. And
so how do they contact you then?
Well, they email me to ask for free samples, and there's a link right there on the NTI website.
So you want them to go to the Jim Boyd website or the NTI?
The NTI devices site, and there's the link there for free samples.
Yeah, ntidevices.com.
Yeah.
Which will default to chairside-splint-store.com, so don't be scared when it does that.
Right.
So we go to NTI devices, there's an S, it's plural, and then that defaults to chairside-splint-store.com, and then continue.
Yeah, and then you'll go to the link that requests free samples. That email request comes right to me. And so I send them back another link for them to go to. There's a certain page, they'll order the device. There's a discount code that makes it for free. And then they're encouraged, if there's ever a problem, they email me, or I'll provide them my cell phone number. They just text me and say, look, I've got a patient in the chair. Can I FaceTime you? Yeah, sure. I mean, that's all I do. So I think that's a blast, but that's the least expensive way to go. And just because it's not expensive doesn't mean it's not legit. So that's how I'd suggest for them to do.
All right. Well, that's easy enough. So if you go to, I'm not very computer literate, but you go to the website and it's got some pull downs. You want to go to the right. There's NTI snore hook order menu, NTI help, online lectures, insights, request samples. It's all right there.
Yeah.
So ntidevices.com, it'll advance to Chairside Splint Story, and also you go to Dental Town. I mean, Jim's answered 7,000 questions. What I love about you is not only did you come out with a product, not only you make it on Diane Sawyer, not only did you get it FDA approved, but hell, you're addicted to your own product. You've answered 7,000 questions. I mean, you're just the American dream. And Jim, you've been blowing my mind for 30 years. Thank you so much for all that you've done for me, for your patients with migraine, for the dental community. You're truly a legend.
Well, thanks. That's nice of you to say so. I love doing it every day.
Well, keep doing it every day. We need you.
All right, man.
All right.
Thanks.
Have a good day.
All righty. Bye.